Hi everyone, today we will analyze a clinical case in which we used Marpe. Here we have a 13-year-old boy. Let's take a look at the photos of his face. Even without intraoral photos, we can see that he has a narrow upper jaw. Look closely at his buccal corridors. Teenagers often don't smile, especially those with uneven teeth. But this is not the problem. Let's take a look at another photo. You can see an elongated face. This is a classic example of the so-called odinoid face. Pay close attention to his nose. It is quite narrow and elongated too. He also has a very pronounced chin and the lower third of his face is enlarged. So buccal corridors, an elongated face, a narrow nose and a prominent chin, which is good for a man. His profile is quite neutral. His upper incisors are positioned normally according to this photo of his smile, and this is also within normal range according to the lateral X-ray. There is some teeth crowding, we will discuss it a bit later. The middle line of his upper jaw coincides with the center of his face, but the lower one is shifted to the left. His teeth on the left are overlapping, and on the right we can see an obvious crossbite. It is also in the area of the lateral incisor. Very poor hygiene, which is quite typical for teenagers. And we need to deal with this problem before we start any orthodontic treatment. I would ask you to take a look at his upper jaw. His teeth are more or less straight there, but they are palatally inclined. The lower teeth are in the lateral part and tilted lingually. You can see it on the intraoral photos, and please note that that is very important. Also look at the base of his lower jaw. Over here, you can even see it in the photo, is the discrepancy between the upper base and the lower base. The side photos show us the disocclusion of the lateral section and the crossbite, as well as the lack of space here on the right. Disocclusion is a very important aspect of diagnostics in terms of vertical growth, which we have already talked about earlier, when we looked at the photos of this boy's face. The lack of space is more significantly visible on occlusive photos, especially for the canine teeth on the left. It needs about twice as much space as it has now. On the opposite side, there is also crowding, but this is not so significant. There is also crowding at the bottom. And take a closer look at the lower teeth again. See how much they are tilted lingually, meaning that the lower jaw can expand. If we change the inclination of the teeth, the lower jaw will be very, very wide. Do you remember I was talking about the bases of the jaws? You can see it even without calculations and CBCT. Also pay attention to the inclination of the upper jaw here. If we create the right shape of the dentition, there will be some potential for expansion. Let's analyze the lateral X-ray. You need to pay attention to this MPSN angle. It is 38 degrees. This patient has a vertical growth type, a high angle, and he will grow vertically further. This is not the peak of his growth. His jaw will grow downwards and rotate clockwise. The degree of the lower incisors inclination is 80 degrees with a norm of 95 degrees. In this case, we have a protrusion on the lower jaw. The upper incisors are 104 degrees with a norm of 102, so there is a small protrusion. When the lower incisors are tilted inward and the upper ones are protruding, it shows a tendency for a mesial bite. By the way, the value of Fitz -2 indicates it as well. The parameters do not correspond to the true class 3, but they indicate a tendency for it. These little nuances should be taken into account when planning treatment. So, to summarize, the boy has a tendency for a mesial bite and a vertical growth. Now, CBCT scans. CBCT is an extremely important diagnostic tool, especially for patients who are planning to use Marpe or any other skeletal extension. In fact, for any patient who undergoes any orthodontic treatment. Please take a look at the inclination of his teeth. They're good. Narrow lower symphysis on the lower jaw is typical for patients with a mesial bite. The lateral incisor is in a cross bite. You can see it on the CBCT, and there is a sufficient amount of bone tissue, so the incisor can be safely tilted forward. Its root is located vestibulary, which indicates that the bodily movement of the tooth is not necessary. Correcting its tilt will be enough. Let's analyze the skeletal width. McNamara analysis. According to McNamara, our patient's skeletal width is calculated from the palatine surfaces of the molars. The skeletal width of our patients is 27.6, with the norm of his age being 35.2. Pronounced skeletal constrictions on the upper jaw. Please remember these numbers. We will make some comparisons later. In order to diagnose and determine the optimal age for the start of the orthodontic treatment, especially for the skeletal expansion, we need to look at the formation of vertebra and the optimal time to start treatment. We need to understand what phase of growth the patient is in, whether he will grow or he is actively growing right now. This is very important. We also pay attention to mid-palatine suture. It is perhaps the main indicator to determine the possibilities and effectiveness of our skeletal expansion. In addition to the non-skeletal suture, we also need to analyze the stage of maturation of zygomaticommaxillary suture. This is a rather specific suture for Marpe. There are axial and sagittal sections. During the course, we will analyze each suture in great detail. I will not dwell upon it right now, because it is rather complex and broad topic. You will have an opportunity to figure out how to display all these sections when analyzing the CBCT. What various tables for each suture will show in terms of the ossification phase, descriptions, and clinical cases. What do you think the growth phase is of this patient? The anatomy of the upper jaw is extremely diverse. The upper jaw has many joints with other bones, but we will discuss just main sutures. So we are planning a skeletal expansion using Marpe. Such expansion is almost always V-shaped. Imagine that there will be a rupture here. And of course, it will affect all the skull structures in this area. The palatal suture itself and zygomaticommaxillary suture. This is also important for the upper jaw traction. We will discuss everything: bones, vessels, nerves, etc. Let's talk about skull anatomy now. A well-known study on the assessment of the mid-palatine suture is the McNamara study. This study proposed a classification for the maturation stages of the median palatal suture. Look at the screen now. Here you can see the table that I made with ABCD stages. Let's see what stages are the best for Marpe. My position is safe expansion. I try to reduce or minimize the load on permanent teeth, and I want to achieve maximum results. This is my main goal when it comes to any expansion. Therefore, I usually use RPE devices on stages A and B when there are baby teeth, because I use RPE exclusively on baby teeth. I'm not afraid of putting excessive load on baby teeth. If you use RPE at these stages, you can achieve great results. Sometimes there are no baby teeth at this phase due to their early removal. In this case, I use Marpe as well. And it can also be used at stages C and D. According to the recent studies, but there are actually not many of them, when I was preparing this lecture for you, I read a lot of articles on this topic, and the most recent studies say that the effectiveness of skeletal expansion is not very high at the stage E, and it is about 58%. That is why it is now recommended to use Sarpi at stages D and E, but it is still debatable. Again, there are not many studies for now, and I know some doctors, for example, Dr. Benedict Williams from Düsseldorf or Professor Van Moon from California, who have excellent results when it comes to extensions in adult patients at stage E, and their treatment is highly efficient. That is why this topic is still debatable and very interesting, and we will definitely discuss it. The zygomatic maxillary suture is an interesting one. It hasn't been studied for long. It also has certain stages, and the maturation stages of the suture correlate with the formation stage of vertebra, and also with formation stage of the mid-palatine suture. We will discuss the two, of course. I use the benefit system, and there are actually several reasons why. First of all, the legal side of the issue. This system is certified in my country and I can use it with absolute safety, and I know that I'm protected. I know that the materials and the system are tested and are therefore safe for the patients. Secondly, I can buy every element of the system. They are high quality and perfectly compatible with each other. There are many consumables. The system is as simple as possible and very convenient to use. So that's why I use it. You start with the installation. Studies have shown that there is so-called T-zone, the most comfortable and stable zone for setting the microimplant in the palatal area. We will discuss this T-zone with you later. It is quite diverse, and there are certain areas in this zone that are best suited for the microimplantation. When we discuss anatomy, I will tell you everything about the bone structure and each area of T-zone. In this case, we have installed 2 microimplants in the premolar region. They are actually very easy to install. I rely on the analog method. We sent everything to the lab, and technician made the simplest device possible, and we transferred it into the oral cavity. In this course, we will look into mistakes every doctor makes, especially those who analyze their medical cases. Even here, take a look at the positioning of these beams. They are located vestibulary. If we use this device at stages D or E, we know that the suture is very dense and it is almost ossified already. Other sutures are dense too. That is why the force that the screw will create when activated should last for as long as possible, and such positioning of the beams can deform them, so the screw may not apply all its strength to the bone. If we had installed beams from the palate area, the structure would have been more solid, unified and rigid, and it is extremely important. In this case, the microimplant was positioned at a certain angle, monocortically. But we will analyze all the types of fixation later. We will also analyze the installation protocols in great details, the activation protocols, etc. They are also very different. I will show you all the stages of expansion. Look at this photo. We installed the device and took pictures from different angles at the appointment. Since there is a cross bite, it is important to open the bite first, so that it is easier to expand the jaws and the teeth could change their own inclination. We used the posterior bite turbos on the 7th teeth. Ideally, you need to put the bite turbos on the 6th teeth as well. Do not forget that the patient has a vertical type of growth. We don't need the extrusion of the lateral teeth because we will have it anyway with any expansion, since the palatine cusps will be lower. On the first stage of expansion, we get a significant diastema. It's about 14 activation turns of the screw. I invite the patient back in 2 weeks to see whether there is an expansion or not. Usually there should be a diastema. This is very important. We've got a good expansion. This is a next visit already. The screw is almost completely untwisted. Our patient was given professional hygiene for the 2nd time. At this stage, please note that we have just put the braces on. I installed them directly and the patient came back without diastema. It closed by itself in just 2 weeks. Teenagers usually don't need to close it, because there is a crowd in there and then it straightens very quickly on its own. We have put the braces on. In this case, this is the diamond system. I work with the passive self-ligation, which is wonderful. I really like it, especially the diamond system. But you can use any braces you have. I usually use soft expansion options. Passive self-ligation allows this. I use round soft arches. You can see that I carefully tie the arch to the tooth and then insert it into the groove and let the patient go home to give his periodontal some time to adjust, so that we can achieve the maximum results. See, the screw is completely untwisted. When there is a significant narrowing of the upper jaw, one screw is often not enough, so sometimes you have to replace the device, remove it, twist the screw, reinstall it, and do another extension, which is exactly what we did here. We got an extension and reached the minimum of a bite. Also remember that he has a huge potential for expansion on the lower jaw, even though the position of his teeth has improved. We haven't reached our goal yet. We now need to use an orthodontic system so it can further expand the lower jaw. We need to get the best of a bite, and that is why we did the repositioning. So we did the repositioning, we expanded it on one side and got a hypercorrection. It was almost a crossbite, but remember that we will put the braces on the lower jaw, so there will be no crossbite, or even the tendency for a crossbite will be corrected. So don't be afraid of it. In fact, very often there is a completely opposite situation when we do not put the braces on the upper jaw and start working with the lower jaw. We will also talk about this, but this is a separate topic. Let's now analyze its skeletal effects. Well, the results are quite impressive. We made overlays of the two CBCT before and after. Because of the braces, we shouldn't evaluate the expansion by the teeth themselves. That is why we looked at the bases. Gray is before, and the colored outline is our result. Plus 3.5 millimeters on each side is quite a good extension. It is impossible to get such an extension using just the braces. The general change in the teeth is plus 10 millimeters. It means that we got 7 millimeters of skeletal width and 3 millimeters of extension at the level of the teeth. Look at the amazing shape we've got. It is very wide. Yes, it is slightly smaller than we wanted around the molars, but in the area of the premolars, the expansion is bigger. It makes sense because the device itself and the microimplant were located closer to the anterior section, so the width in the anterior section is more pronounced when we use this configuration of the device. Let's evaluate the boy's growth. It is clear that he is grown. In fact, we treated him during the time of his active growth. This is both good and bad because he grew vertically and his bite opened during the treatment. His nose also grew, slightly affecting his upper lip. The incisors remained almost the same, provided there was crowding and a significant lack of space, meaning we did not get a protrusion. The space we need, we got due to expansion. It is also very good. Now let's evaluate the final results. What a beautiful and wide smile he has now. Could we possibly get the same results if we use just the braces? I don't think so. Yes, we would get even teeth, but there would also be a protrusion and we would definitely not make it so wide. So I'm extremely happy with our results. Marpe gives you an opportunity to get excellent results. It had a positive effect on the boy's airways. He began to breathe through his nose normally. He stopped getting sick, which in turn had a very positive effect on his overall health too. And of course, his smile. I guess he will conquer everyone now. During this course, we will study everything in details. We will discuss each state of work with the braces. And also common mistakes. Mistakes are important. I'm not ashamed of them and talk about them openly. You will be able to see it all so that you can learn from my mistakes but not from your own. Of course, there were a lot of them, even in this clinical case. So thank you for listening. I was very happy to share all of this with you.